My name is Fliss Murta, and I would like to present on this study on behalf of the team working in Hull. In Hull, there was a new centre developed, the Jean Bishop Integrated Care Centre, which has been delivering a comprehensive anticipatory care service for older people at risk of frailty based on a comprehensive geriatric assessment. When we undertook this study, we wanted to characterise the intervention, what components, actions, referrals and coordination was being delivered, but also determine whether this new service was effective in improving overall well-being and quality of life for these older people living with severe frailty. So we set up a non-randomised controlled trial. The setting was the care centre and the local GP practices. We included participants who were over 65, who were at risk of severe frailty from the Electronic Frailty Index score, and were able to communicate in English. The intervention was the service itself, the new Integrated Care Centre service. And the control were patients in the local area who were not receiving that service, but their standard GP care. They were of similar age and frailty. We undertook 3 data collection points at baseline, at 2 to 4 weeks, and at 10 to 14 weeks. Our primary outcome was well-being measured using the Integrated Palliative Outcome Scale. This is a brief measure which has been based on the symptoms and other concerns that people with illness, with advanced illness themselves report. And it's a good measure of overall well-being in an older, sicker population. We also used as a secondary outcome quality of life measured using EQ5D. So this is the demographic and clinical characteristics of our participants. You can see that the age in the 2 groups is very close. We also looked at other demographic variables. Living alone we considered to be particularly important, and we've got a similar proportion, 46% in both groups. There was a bit of variation in the deprivation status as measured through IMD deciles, and in the functional status as measured using the Australia Modified Karnofsky Performance Score. However, we adjust for this in the analysis, as I will show you later. This shows you what the service was actually delivering. So everybody had a detailed physical assessment, an assessment of their function, mobility and balance, some brief psychological assessment, and 16% of the cohort went on to have a more detailed psychological or psychiatric assessment because of concerns. All of the cohort had social environmental assessments. All of them had review of medication and advice on changing and adapting medication. All had a personalised care planning approach, and they were all offered the opportunity to consider future care planning. About half of the cohort went on to complete a detailed respect form. This is a national form which is used in our area to capture preferences about specific interventions, including CPR. About 45% had referrals to other clinics or professionals, and about 1 in 4 had investigations, blood test, x-rays, etc. So these are the baseline primary and secondary outcomes. So you can see that on average, both intervention and control group have a median IPOS score of around 18. Now, IPOS with a higher score represents more symptoms and concerns, and a lower score represents fewer symptoms and concerns. This is about moderate and perhaps what we would expect for an older, frail population. Similarly, the quality of life scores were very similar, and again, somewhat impaired, as you would expect in a population of this type. Here's the data at time point 1, 2 to 4 weeks. And what you immediately see is a marked difference between the median IPOS score in the intervention group and the control group. So the intervention group have had a drop of, on average, -5 points on IPOS. So that represents an improvement in symptoms and other concerns, whereas the control group have had a small increase. And you similarly see a small improvement in quality of life, although the effect is not so marked. We wanted to understand whether this was sustained at 10 to 14 weeks, because it's important that the service doesn't just improve well-being in the short term, but that it has a sustained benefit. And you can see that the improvement in well-being in the intervention group is maintained at 10 to 14 weeks. And similarly, the control group have had a slight worsening as before. Again, the change in quality of life is much less marked. We also undertook regression analysis, and we tested different approaches to increase the rigor of what we were doing. And you can see here with either a t-test approach, the formal regression analysis, or a detailed propensity score matching method, particularly matching on functional status and deprivation scores, you can see that the effect estimate is very similar across all these different methods. So in conclusion, we can say this service does seem to improve the overall well-being of older people living with frailty at 2 to 4 weeks, and that improvement is sustained at 3 months. There is also an effect on quality of life, but that's much smaller. Choosing the right primary outcome measure has been very important for us. We found notably greater change in well-being than quality of life. And I think this is because the IPOS is designed to measure the symptoms and concerns of these older people with advanced illness. And it's much more specific. Quality of life, in contrast, is subject to a much wider range of influences. And I guess this trial provides some conclusive evidence that the model of care works well in this population. The components are clearly delineated, and the approach of the service could be adopted more widely. There is a need for wider testing of this model of care with other populations and in other settings and contexts. Thank you.